To the Care Answered webinar, Safe Road Home. I'm so excited that you're here with us. And we're going to be talking about getting home safely from rehab or skilled nursing facility. It's been brought to you by popular demand from our last Safe Road Home. People wanted to know more information. So my name is Nicole Christensen. I'm the CEO of Care Answered. We provide healthcare coordination and patient advocacy. I'm a board certified patient advocate and author of the book From Crisis to Calm. And I'm here with my friend and colleague, Maureen Nickel. She is a certified senior advisor and owner of Bright Star Care, which provides nursing and home health aid care, and she's going to tell us a little bit about that later because she's crucial to this webinar. So thank you for joining us, Maureen. As I always say, because it is true, I only work with the best, and Maureen is definitely one of them. So you're welcome. Thank you for being here. So without further ado, let's get started. Well, the topics that we're going to cover today are preparing for discharge. What's the goal? Who do you go to? Then what's needed at home? Physicians, medications, insurance, home care, all of those kinds of things, and how to get it, and how to find that home care. So starting the path home safely. And then we'll end with a little bit of what is available if you need long-term care, potentially for the future for financial reasons. We talked a lot about that in previous webinars, but I'm just going to touch on it very briefly. Okay, so all of you who know me have heard me say ad nauseum probably, discharge plan starts at admission. So you need to be thinking about going home as soon as you are in a healthcare facility, if that's your goal. So what kind of understanding do we as patients need to know, or as an advocate or a caregiver, loved one? Something called baseline, right? So if you are in a hospital or in a skilled nursing facility, they saw you as you come in, right? Likely not your best day. So keep that in mind and make sure the entire care team is informed about what your baseline before your hospitalization. What were you able to do? Were you walking 3 miles a day? Were you able to get up and now you can't transfer from sitting to standing? All of those things are important so they understand the patient as a whole, not just what they're seeing in front of them. So that is a really important information to share so that you can better understand. And then what are then the physical goals? So now we know the baseline. The care team at the facility is now aware of the baseline. What are their goals for you now or for your loved one? Then who are we talking to? What are we talking about when we talk about these goals? It's the entire care team in the facility. So doctors, physical therapy, all the therapies, occupational therapists, speech therapists, whatever that's being utilized or needed, the nurses, the dietitians, the social workers, and case managers, all of them play a part in the whole person so that the discharge plan is thorough and really hitting all of the points. Because as we know, right, if we're not eating in the skilled nursing facility, but we had a good appetite before, that's going to play a part in our recovery and therefore our discharge. So we want to make sure we're talking about all of those parts of the puzzle, the parts of the patient. The other thing that one needs to think of when home is the goal is what devices might we need? Will we need a cane? Will we need a walker? Will we need a wheelchair? Will we need a ramp in the home? Will we need other things happening or renovations in our home to make it possible? I have to say, I started advocacy over 20 years ago with seniors in Washington, D.C. And sadly, the stories I still hear, very sad and horrifying, in my opinion, stories of people that are discharged home and they're in a wheelchair when they're coming out and have no access to get into their home. There's stairs into their home. This hasn't been discussed thoroughly. So it's just so important that we really ask those questions, and don't take it for granted if you're the advocate or the patient or a loved one that all of these topics are going to be addressed. It can slip through the cracks, so it's really important to ask these questions. Other things to keep in mind when we're talking about discharge. What support at home do we have? Whether that's a physical person at home that lives with you or your community. Every time that we're discharged from a healthcare facility, it's a difficult time, right? You don't necessarily come back just as you were 2 days before you went into the hospital. You need that support, whether it's by telephone or a person or what have you. So keep in mind what the supports at home are and articulate them. Then there's the medication list. Always, 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 always have the medication list. So you want to know what medications that one is leaving with, and the pharmacy that it's going to be sent to. One of the things that I advise my clients is when we're being discharged, if there's new medications, or any medications, honestly, go home in that discharge with a week's supply, whatever that they can provide, because you don't want to go home without a medication that is desperately needed. And you don't want to go to your pharmacy and find out it was called in, but they don't have it yet. You want to make sure that you actually have those medications on hand, ready to take when you get home. So those are really important things to make sure are intact. And then community doctors, those that you're seeing within the community, they may or may not know that you were hospitalized or in a healthcare facility at all. Make sure you alert them even when you're in the hospital. You can also make plans to have a follow-up visit with them. There might be new doctors that you might need to see, new specialists. Just make sure that they've given you that information about specialists that they suggest, and that you've called and potentially an appointment's already made to follow up. Again, you do not want those things falling through the cracks. And transportation home. Sometimes we can't, hop in the car with our loved one and get home. So you want to make sure that that is being organized and you know exactly what that looks like. Other little things that people sometimes forget about is if you had clothes, how are they getting home? How do we make sure that we get those home, especially when we're not in the facility if we're a loved one? So we need to make sure that all those loose ends are tied up so that they're not coming home without their favorite, shirt, jacket, sweater. We make sure that we get all of our items back. Any questions?
I think this list is great, Nicole.
Mm-hmm.
I think also one of the big problems that we sometimes have, especially if there's no family member involved, when there is absolutely no food in the home. Something that people just don't think of. Or what's even sometimes worse is if the person has been gone 3, 4, 5, 6 weeks, if they had a hospital stay and then a 30-day stay, there's old food in the fridge. So oftentimes, if they are having home care, we will have the aide go in there and clean out that fridge of all the old things, and we'll do a food run also, finding out what their favorite foods are, just if it's for a day or two, and then they get their bearings and can figure it all out. But food is to me as equally as important as that medication.
Absolutely. That's an excellent, excellent point. Thank you.
Mhm.
So now I'm going to talk a little bit about what insurance covers at home. People often get confused about this. So, for example, for Medicare, they'll hear something like, oh, Medicare will cover care in the home. And to them, that might mean, okay, mom needs 10 hours of care at home and it's going to be covered. That is 99% of the time not the case when we're talking about Medicare type of coverage. So, what is it? What does it really mean? First of all, I'm going to talk about when the evaluation takes place. So, when I say evaluation, I mean, when do we find out how much care we're going to get or what kind of care we're going to get? Oftentimes, that is slated to be done by a specific agency, probably 24 to 48 hours after you're home. So a lot of times people are thinking, okay, that'll be in place as soon as I get home through Medicare. Likely not. They won't even come to evaluate again until 24 to 48 hours later. And so that evaluation, generally in my experience, is done by a nurse. And then the nurse kind of sees what's going on. Potentially, the nurse will come repeatedly, especially if it's there's a skilled care need, like a wound care nurse or something like that. But they're kind of making the determination of what you need. You may need something like physical therapy, occupational therapy, speech therapy that they can also bring to your home. When that is going to be scheduled is part of the team that's providing the home care. And then there's home health aides. Again, this is where, like I mentioned before, where people think, oh, it's going to be a number of hours. Generally not. Generally, when assessed for Medicare coverage, they may come for an hour, 2 to 3 times a week. They're generally not going to be there for blocks of time, hours at a time. In addition, when they come is very scattered. It's not as if they're going to come Tuesday at 9 and Thursday at 10. It can be kind of throughout the day, which can be very exhausting and not helpful, because there's sometimes they come, for whatever reason, they come at 3 o'clock and they're for helping you take a shower. And that's kind of not when you would generally take a shower, that kind of thing. And we advocate a lot in this regard to make sure that the care is in place. But that's kind of what it looks like as far as care in the home that's covered by Medicare. Maureen, did you want to add to that?
No, I just agree with you completely that it's the system, and we have a difficult time changing that system. Not too long ago, we would see people get 5 hours, 4 hours of care, 5 days a week. Then we saw that capitated to about a 2 times 3. And now, as you pointed out, Nicole, it's more like a bath visit. 1 or 2 hours, 2 days a week. The nurse care hasn't really changed. That will still be usually once a week that the nurse will come in. But I think what's most disconcerting is the lack of continuity with the hours. That you used to have someone, you knew that aide was showing between 8 and 12, and now that's not the case. So maybe there is an adult child who is coming in at 3 o'clock, 4 o'clock. Kids are home from school, they come over, and now you have the aide there, and you really don't need all those people there. You really wanted the security and the comfort to know somebody was visiting mom that morning, to help her in the shower or whatever, just sponge bath, whatever it was. So it's very difficult to rely on the home health aides now with Medicare services. Very sad, because it's a system we pay into for so many years, but that's the reality of what we're seeing right now.
Yeah, it's a lot of changes. It used to be that they would evaluate and you could potentially have care the same day you were discharged, and now that's not the case either.
Mm,
So
right.
it is difficult. Okay. So when we say home care, um, there is a lot of different things that people can think of in home care. So I'm just going to go over some of the common terminologies. One is companion care. Now, companion care is often thought of as socialization as well, right? So to have somebody there that is a companion to someone. They generally don't cover um, that ADLs, activities of daily living. They're generally not certified. And so for something like showering, like we were just talking about, or even transferring, and if they actually need assistance ambulating, um, that might not be in their wheelhouse. So, just know that so that you can ask all of the right questions, which Maureen will go on to in a moment, so that you understand the care that they can actually provide. Then, commonly is the home health aide, which provides more of those skilled. They're certified and they do provide and offer that assistance with that activities of daily living. They'll also do things like, a light cleaning and meal preparation. And then there's nursing. So nursing is obviously skilled. Whatever it is that you need that requires a nurse's care, again, that would be less like activities of daily living potentially, and more like if there's feeding issues, a trach issue, wound care, things like that, that a nurse needs to be involved. So there are different levels of care, and within that discharge plan, which again you're starting planning upon admission, you want to know what the care needs truly are at home, because they're not in a facility anymore, which means they do not have nurses around them all the time. So what does that mean realistically in the home? And have those deep conversations with the entire care team, whether it's in a care plan meeting or discharge planning. um, you need to know all of those details, because there's going to be a lot that does not come into the mind, because you're just so excited to have your loved one home and they're so excited to come home, that these things can fall through the cracks. So slow it down. You can talk to your loved one and see what's going on for them. So if they're getting assistance in the shower, they feel unsteady, um, that might be assistance that they need. So bring up those questions and ask. Okay, now Maureen will take it away from here, and she's going to go through some of the questions that we really need to be asking. So again, we have the right care in place.
Thanks, Nicole. While you were talking about the different types of care on the previous screen, with the companion and the HHA, and then skilled care, or as you put, nursing care, I was thinking to myself, I wish I had $1 for every time somebody called me and said, all I need is a companion for mom. That's all I need. And I'd say, okay, great. What do you need that companion to do? Well, I need her to get into the shower, give her a shower, and then you have to take them through the steps. And it is very difficult if you've never navigated this before,
Absolutely.
and when it's all so new to you. So the way I try to explain it to people, it helps them really grasp the whole idea is a companion cannot do anything hands-on. A companion cannot touch your loved one. So they can't help dress them, toilet them, feed them if need be. They can't bathe them. They can't touch them, transferring them. And when people hear that, they seem to get then the picture and they understand it a little bit more. And sometime, to your point, Nicole, it is just for socialization. So it is a companion. The question, though, if you're dealing with someone that is strictly a companion agency, keep in mind that companion agencies are not regulated by New York State. Department of Health does no surveys. Department of Health isn't even always aware that they exist. They are not regulated. So unlike agencies that do personal care, the hands-on HHA care and skilled care, we're totally regulated, and we should be. Bright Star is not only regulated through the DOH as a licensed LICSR, but we're also joint commissioned. So there's two bodies of people looking at you. That's a good thing. You want that. So a personal care agency not only has nurses involved who trains the aides, who does all their competencies, who goes in the first time and shows them everything that needs to be done, who's always there. Usually our nurses are about 40 minutes away. That's how quickly we can get into the home if there's any type of an issue. The first question you need to ask an agency, if you're looking for just companion care, you just want someone to take mom out to their doctor's appointments, to the park, to sit and just play cards with them. What are your background checks? All right, so the companion isn't trained. Okay, that might be okay if mom doesn't have any real needs, but do you do fingerprinting? Do you do background checks? Do you do drug testing? I don't know about you, but I don't want anyone taking care of my mom if those things aren't in place, even if it is just for companion care. So that's a very important question to ask if you are dealing strictly with a companion care agency. There are other agencies that do the full consortium of care. They do companion personal care and skilled care. So if you're dealing with a personal care agency, you ask similar questions. One of the main questions is there a nurse that oversees the care? So does a nurse come in and do the evaluation, write up a plan of care, so that aide that comes in always knows what is expected of them? It's called the plan of care. That must always be in place. And then does that nurse come in to do supervisory visits and to do further assessment of your loved one? So they're doing the supervisory visit is of the aide to make sure everything is getting done. But is that aide available? So if I call you, do I get a live person? If mom isn't feeling well, I'll give you just a perfect example very quickly. We have, especially older women, we seem to get more UTIs. And so an aide will call, Mrs. So-and-so isn't quite herself today, maybe a little disoriented, which is a real red flag for a possible UTI. We have the nurse go in and we'll take a specimen, bring it to the lab. It will come back positive almost 90% of the time. We call that into the doctor, and the doctor writes the script for the Cipro. The nurse will usually go to the pharmacy and pick it up, and we have them on an antibiotic within hours. So it's a trained aide, first of all, because they knew that they needed to call, but there was someone to call. So that's why having that nurse there all the time, nurses, plural, is extremely important. If you're dealing with a skilled care agency, we are an agency that does both personal care and skilled care. But if you're dealing with a skilled care agency, it's all nurses. So that question really doesn't have to get asked as much. But still, the are you bonded, are you insured? What happens if an aide falls and slips in my house? Who's taking care of that? We do. You assume no responsibility whatsoever. A licensed agency does. They take care of that. You are not hiring that aide. The aide is the hire of the agency. So all employment taxes, every tax that needs to be taken out is for workman's comp, for unemployment. That's all assumed by the agency. So if they're a licensed agency, the state should have done all that checking and should know that, but always a good question for you to ask. Then the technologies are something that's unique to all agencies. And like everything else in life, all agencies are not created equal. Do you have a GPS service? If I call you right now and say, where is that aide? Is she on the way to my mom's house? Did she get there yet? How do I know that? And it's not cheap. It's a costly function to have, but boy, is it worth it. I can tell you if the aide is a mile away, if they're 10 minutes away, if they're already in mom's house, if they checked in. We also have verification of the checklist, what they've already done. Oh, well, they gave mom the bath already. Sometimes they think we're kidding. They don't think that we really know it, but they're able to check off the task list. It's all on their mobile device. So everything is secure, encrypted, but they're able to go in and check off the tasks as they do them. So GPS, knowing where they are and knowing the skills checkoff list, also very important. So a good question to ask, what are your technologies that you have in place? Insured for accidents at home, I think I already went over that. Can a caregiver be trained for a specific skill set? Absolutely. I think all of my aides are trained for dementia and Alzheimer's because that's so important, because that is one of the probably the biggest disease morbidity that we now deal with is Alzheimer's and dementia. So it takes a very special person and special training to know to have that patience to deal with a person who's going to repeat continually. They need to understand the process to be able to work with that individual. So dementia and Alzheimer's training is extremely important. But falls prevention, Nicole mentioned earlier, transferring from bed to wheelchair, from wheelchair to toilet, into the shower, into the car, if they're taking them to a doctor's appointment. So specific trainings need to be had, especially when people have certain mobility issues. Do they have their skills training in fall prevention? Also, though, basic trainings, HIPAA law, very important. And now, of course, with COVID, what is it that we need to do now that we haven't done before? So it's two different sets of rules depending on if we're going into a COVID positive patient or if we're going into a person that is negative. The aides have all their PPE equipment. Something I just wanted to point out, I don't know if you can see this or not. This is, can you see this? Am I holding it up okay? This is a PPE kit. It's just a plastic bag. I'm not going to open it because it's sterile right now. And when any licensed agency walks into your house, this should walk along with it, with the aid. In here is a disposable gown. There's hand sanitizer. There's a face mask. There is also a CPR mask. And there are gloves. And there are towelettes. That needs to always be in that home. The aides carry all this equipment in their cars as well, but that needs to be in the home at all times. That was pre-COVID. I hear so many agencies saying, oh, well, we now send them in with hand sanitizer. You were always supposed to send them in with hand sanitizer. That's not something new. What is new is the N95 masks, the goggles, the face shield. They must wear the N95 in the home and the face goggles and the shield if a person is positive. If a person is negative, and of course the aides they've been tested, they're negative, then they still must always keep on their surgery mask. The surgical mask must always be on. That's like the blue ones, the disposable ones that we do. We don't do cross-contamination. We don't have aides work in a rehab, because sometimes they do bedside service in a rehab or an assisted living, and then be in a home. It's one or another, which is definitely adding to the aide shortage that we have right now. Sometimes we would have an aide who worked in the home during the day, and on their own, they would work 2 or 3 hours in a rehab. We can no longer allow that. We don't allow that. I know some agencies still are. That's for everybody's protection. If an aide takes Public transportation, I'm fortunate that most of my aides do drive, but if they take public transportation, they change their clothes when they get to the client's house, and when they go back home, we tell them to change their clothes as well. Again, for everyone's protection. Is there a, what are the rates that you definitely have to ask, because different rates, buyer beware. If it's a very reasonable rate, I just heard of somebody was charging $25. They were an agency in Brooklyn, I think, but they were sending aides to Nassau County. And I questioned that when the person told me, and it turned out that it was a companion care agency. They couldn't have done all the things that the family wanted to, but they didn't ask that question. So sometimes if it sounds too good, it probably is. So, really get that question in. Are you a licensed agency? Can you, bathe or dress my loved one? And then you can kind of gauge if that's accurate by the rate they're giving you also. Also, there is the DOH website where you can go in, put in home care agencies, put in the name of the agency, and immediately it will come up whether it's a licensed agency or not. If it doesn't come up at all, then it's not in their system, then it's not a licensed agency. No length of time should be required for you to have services. That's just not a best practice of how licensed agencies work. If they tell you, yes, you have to have care for a month or 2 weeks or 3, whatever it is, look elsewhere. Look elsewhere, because mom can improve tremendously. Sometimes we're so nervous when someone is discharged from a hospital or a rehab. We want the care set up. We get home and we're pleasantly surprised that they're doing quite well. And we either want to downgrade the care. Maybe we said we wanted 8 hours a day. Maybe now we only want 4 hours. Maybe we only need 3 days a week. So there should be no binding contract whatsoever. The day you pick up the phone and you say, I no longer need care, should be the last day of care, and there should be no strings attached to that. So that's extremely important. You must sign a service agreement. That's a state reg. We're not permitted to be in a home unless you've signed and give us permission to go in. But signing a service agreement and agreeing to the rate that we're going to charge is very different than signing a contract that says we have to be there for a specific period of time. So there's a big difference there. Nicole, that's the end of the sheet that I can see. Was there something else there?
And while you're checking, Maureen, there's a question from Olga about whether you should request or require that the person who needs assistant wears a mask. And what if that person refuses?
So again, if the person is not showing any COVID symptoms, we are getting more and more of the clients are getting vaccinated, more clients than AIDS, but that's a great thing that we are getting so many people vaccinated. But if there are no symptoms, no coughing, no secretions, no sneezing, then we leave it up to the person. We do request that they wear a mask, but if they find it very difficult to do so, we have people on oxygen. It makes it very, very difficult to do so. We don't really force that issue with them. If we're talking about a COVID positive patient, that's a different story.
So thank you, Maureen. That was very, very helpful and thorough. Now, you talked a little bit about it in just previously, but there's a difference now, right? There's a difference in potential availability and the things that go on. Again, you touched on the equipment being worn, but can you tell us a little bit more about what's different today, which could change tomorrow? We understand, and can be vastly different from yesterday. But what are you seeing? What's different now?
About in terms of the availability of aids?
Availability, exactly.
There's a scarcity of aids. There was pre-COVID fewer and fewer aids, and now even more so. And I did touch upon it. Some of it is our doing, because we're not letting an aid work in a facility and in a home. So there's a shortage there that we
Right.
have created.
And that's particular to Bright Star right now.
Well, I would say most agencies,
Okay.
you would hope that they're not doing the cross contamination, that they're not allowing them go places. Another good question to ask them. But I'm hearing that many of us will not send into a rehab and then have the person work in the home as well. But there is also a shortage because um, the aides are afraid of COVID, and rightly so, because they are so exposed and vulnerable. Many of them have childcare issues, and you have to weigh things. If or some people have told me that they're now paying double for their childcare. These prices all have gone up. So if you are able to work and you want to work, but you're now paying more in childcare, plus you are entitled to unemployment benefits, you have to weigh it and see what works best for you and your family. So there are those that have the issues, are able to get the unemployment, and so they are not taking cases right now. So that's created a great vacuum, a very big shortage. We actually, in some cases, have had nurses go in, and the clients love it because they're not being charged for a skilled, nurse to go in, and they will stay with them for a while if an aide can get there, but maybe not at 8 a.m. because of a childcare issue. They can now not get there until 10 a.m. So we'll have a nurse there for 2 hours. Everybody loves it, and except me, and and then the aide will come in. So we do what we absolutely can. Sometimes we have to do different hours and days that the family has to work with us a little bit. Maybe they wanted Monday, Wednesday, Friday, when our availability might be Monday, Tuesday, Friday, and the families are extremely grateful. They know what the shortage is. They know how difficult it is, especially on the short hours cases. So they really work with us, and we try to do the very best we can.
Yeah, it the reality when I speak with my clients is that we're all humans, right? So everybody it has a level of comfort or discomfort, and so we're all working in the same kind of feel and understanding. So I find that people are as patient as one can be in this situation, because then it's their people too, right? Their clients, their loved ones, and it's just a very, very difficult time. But it's wonderful to know that agencies like yours are doing everything that they can to make it easier for loved ones and patients.
And that's where retraining came in. It's not easy to get your aides in and train them because some have to be absolutely in person. You can't do everything via Zoom. So to keeping a safe environment, to getting, instead of having 12 aides in or 10 aides in, you can only do 2 or 3 because you had to social distance them. But you talked about anxieties, Nicole, and your level of comfortability. When you retrain aides, even though they've had this training, but when you retrain them on proper hand hygiene, when you retrain them on what an airborne pathogen is, when you retrain them and send them for actual fit mask testing, where they put on an N95 mask and they put different scents in front of them. And if they know they can't smell that scent, they know that they really are secured from even the COVID virus entering into their nasal, passages. That makes them feel more comfortable. Because at first, before we did a lot of fit mask testing, they would say, but is this really working? This N95, is it really working? So it's easing that level of comfortability too, to make them feel that you're in as safe an environment as possible. So I think that's very important as well, to do those retrainings, even though it is time consuming and costly. It's worth doing it because it makes everybody feel more relaxed.
Absolutely. And if they're more relaxed and less anxious, then
Absolutely.
that certainly transfers to
They're
their
offering better
patient.
care then, aren't they?
Absolutely. Absolutely. Um, and so one of the things that you said, and I think you mentioned it before here, you talked about the PPE equipment and the regulations, and how families should ask about the pandemic precautions, um, and then requesting an aid. Let's talk about that last bullet point, because I think that also plays a part into Olga's question as well.
Sure. So the question that we get asked a lot is, what do the aides do when they get up in the morning? How do they prepare themselves? And every aide has a checklist that they need to go through, and then they put that on their mobile device. So we see exactly that they did that every morning. One is a temperature check. The aides are not only taking their temperatures twice a day, they're taking their clients' temperatures twice a day. Aides were always allowed to take temps. What has now been relaxed, what an aide is also allowed to do, is to do pulse ox. So in addition to having their infrared no-touch thermometers, they also have a pulse ox reader. So because that's the first indicator that the person that they're taking care of may be ill, if they're not getting,
Yep.
if their oxygen saturation isn't well. So they're doing that twice a day as well. Families are very relieved to hear that, because some of them, as much as they tell us they try to keep their other family members out, people anxious to see grandma, they're anxious to see grandpa, so they don't always know. Our guard has been let down. We've let it go a little bit. A year ago we wouldn't even be having this conversation because nobody went near grandma and grandpa. That's been different these days. So I think one of the things, though, that you can certainly request, it is not a state mandate, that a home health aides working in the home, different from a CNA. CNA works in hospitals and rehabs, that's certified nurse assistant. In the home in New York State, it's different in Connecticut, different in New Jersey. In New York State, it's an HHA, a home health aide that works in the home. It is not a mandate that they be tested for COVID. Why? Because it's very difficult when they're all going to different homes. Where do they get tested? It's not like they're all going to the same place, and a rehab can test people in their lobby or at their nurse's station or whatever. It's different when they're in their home. Nurse aides are willing to go for testing. Most of them, they don't like going all the time because they feel that they're getting a sensitivity in their nose with the nasal swabs. My suggestion is to families that you ask us, can you send me an aide who just was tested, or can I have an aide that will be tested every week? So then I'm, as the employer, have not told them, because I'm not permitted to tell them to go get tested, but I can say this particular family has asked that you go for testing every week. So I think that's very important that people do. And if the aide doesn't want to get tested every week, they say, listen, I've tested, so what? I know the symptoms, I'm not sick. Some of them were exposed to COVID. They say I have the antibodies already for it. Then they don't get that case, and that's fine. They understand that, so, but if a family asks, you will get an aide that gets tested.
And the same thing for vaccinated?
Well, it's much easier, of course, to get people tested than it is vaccinated. We're still having the conversations with aides. Many of them do not want to get vaccinated. I find that less family members are asking for vaccinated aides because they understand that many aides do not want to become vaccinated. They understand the issues with getting the appointments and getting vaccinated, as opposed to getting tested. Back just a few months ago, it was very difficult to get tested too. So now that doesn't exist anymore. It's very easy to get tested. And I'm not talking about a rapid test. We don't accept rapid tests. It is the PCR, and we're getting results back in 24 hours. So it's easy, it's convenient, because there are so many places that do it. So most families will ask for the testing rather than the vaccine. If that is truly a requirement of yours to have an aide vaccinated, the scarcity of aides will be that much greater, and you might not be able to get services to begin exactly when you want. But certainly that's something, if that's a priority of yours, you should always ask for what you want. Always ask. The most we can say is, no, we can't do that, right?
Absolutely, absolutely. Ask and ask and ask away,
You bet.
and make sure that you understand the answer, whatever it is.
Mhm.
The one thing that I just wanted to touch back on, since we're talking about the pandemic and the things that have changed, is likely your loved one is also going to be tested before they leave if they haven't told you about that. So we're again talking about discharge upon admission, right? So asking to make sure that they're free and clear before they leave, and making sure you have that information is also essential, because even if they still come home and you think that that's the best thing and they think that's the best thing, you want to make sure that you're prepared for this. Obviously, if they're positive, when you're getting care in the home, you would let the agencies know that as well, because they have precautions, they have aides that will go into homes where the patient is COVID positive, but they need to know so that they can take all of those precautions. Is that safe to say, Maureen?
The issue with that is that once you have COVID, even though you've passed the 14 days, even though you might be asymptomatic maybe the entire time or even now, you can still test positive for quite some time afterwards.
Mm-hmm.
So we get hospital discharges where they say, listen, mom has had no symptoms. She did have symptoms. The hospital is ready to discharge her. It's been 14 days. She's still testing positive. So we take every precaution as if that person was COVID positive, but we know very often they no longer are. That's just how the test is coming out.
Got it. Great. Thank you for sharing that as well. So now briefly, I'm just going to talk about long-term care. Obviously, the services that we talked about, other than the Medicare, there's a rate involved, and which Maureen talked about, asking what the cost would be. But in addition to long-term care, we talked a little bit about the Medicare coverage of the potential PT, OT, meaning physical therapy, occupational therapy, and potentially speech therapy. If that time has ended, they're discharged from that service at home, you can go to your doctor and ask for a prescription for more.
Mm-hmm.
And there's a lot of agencies, many, again, I work with the best, many of whom I work with, that do go into the home and provide it, as well as they are certainly working with people within facilities at this point. Then the other way to cover those costs, so that would still be covered under your insurance, what I'm talking about right now, generally through Medicare B if they're coming into your home. And then the other ways financially to afford this skilled service for a long period of time would be long-term care insurance, which we've covered before, and community Medicaid, which we've also covered before. So those are also alternatives. So again, the therapies, the physical therapy, occupational therapy, and speech therapy can often be prescribed by their community doctor for a longer period of time than just the Medicare coverage that was just after discharge.
So Nicole, on the long-term care, we just call it LTC insurance, that will cover home care, and the hours and the days is based on your specific policy, whatever
Right.
is covered there. As far as the skilled care, like we provide infusion care, that goes back to the person's Medicare. The Medicare will pick up their infusion care, that portion of the skilled. Much like the PT and OT, infusion is covered under that. Medications, the pharmacy, as well as the nursing services. And then the long-term care just covers the HHA typically.
Thank you for the clarification. Yes. Okay. So I just have here some of the webinars that I discussed, because they have more information, goes more in depth into community Medicaid, into long-term care insurance. We do a lot of advocacy in regard to all of those things. And as well as the transition we did our last Safe Road Home was about the transition from hospital to skilled facility. So you can look those up. They're on the website as well as those are links. And so with that said, I want to thank everybody for joining us today. It was a pleasure having you. I hope it answered the questions that you had. I'm going to look in the chat again to see if there's some remaining questions. Okay. Would you request? Okay. Would you require that a person who needs help wears a mask? That's what you talked about a little bit before, Maureen,
Right.
from Olga, and if they refuse to wear a mask. So I think the question was about the aides themselves.
The aides are always in a mask. They
Mhm.
stay always in a mask if it's a non-COVID positive patient.
Oh, okay. She did say the person who needs help. So you answered that question already.
Yeah.
I'm sorry.
So, but the aide is always in a mask. They're either in the N95, it's COVID positive, COVID negative. They're in their regular surgery mask.
Okay, great. So thank you. I don't see any other questions. Thanks so much for being here. Thanks for your great questions. And Maureen, thank you so much for all of
Thank
that
you,
important
Nicole,
information.
for running these. These are so helpful for people.
Thank
Thank you very much.
We hope it makes it less daunting.
Yes, right. That's why we're here, to give out the information so people can feel more comfortable.
I'm just very surprised to hear that some aides do not want to be vaccinated. I thought that healthcare providers, well, like, are the ones who really want to and should be vaccinated. I was really surprised to hear that.
Well, I think Nicole and I discussed that yesterday, and we discussed about the history there, that there are so many reasons why a home health aide is leery to get the testing. I don't know if you want to touch on that, Nicole.
I don't know. I don't think you made that webinar, Olga, but I did a webinar on Black Health Matters, and there's a clear and unfortunately systemic reason why Black and Brown people are more wary of the vaccine. And so that plays a part into it as well. So when you have a large population providing home care who are in the Black and Brown community, you have to recognize the whole basis way before now that their intrepidation really lies in, and it's very, very valid. And I think as communities of all of us can help to learn more about it so that we can all help each other, because especially in this pandemic, no one's safe until everybody's safe.
Mm-hmm.
Yeah, and hopefully it will change. But
Yes.
I know for myself that for quite a while, I myself didn't want to be vaccinated for health reasons. I was not very comfortable. And then looking at my friends, people around me who did have it, I thought, you know what, I'm going to do it. And I'm going to have my second one at the end of March.
Good for you, Olga.
But, I thought, you know what, I'm going to do it. And hopefully people will change their minds unless they cannot be vaccinated for some health, considerations. I don't know.
Right. Hopefully we'll all, again, it's a worldwide problem, right? So it really matters that we all take care of each other and be informed. Our healthcare providers going out there and informing all communities and representing all communities so that we all have the information. And again, we ask until we understand. This is not easy stuff. So we need to really be able to understand so that we can make the best decisions for ourselves and our communities.
Nicole, there's one question here from Michelle. Do
yes.
we have any agencies that will provide this in the Montauk area, this being a presentation like yours?
No, I think she's talking about home care. Michelle, are you still on?
I am. Can you hear me?
Yes, we can.
Yes.
Yeah, I'm looking for any agencies that provide any of this type of care out here. I've been doing this for like 20 years and it's so difficult to get individuals out here.
Yes, East End is very challenging to staff. And that's why most agencies, I am licensed for Nassau and Suffolk counties, but to go into the Montauk Hamptons area usually only works if it's for live-in care. So it's usually just a 4-3 split. One aide stays for 4 days, another aide stays for 3 days, and we're able to work it that way. When it's for shifts, 8 hours a day or 4 hours or less a day, it is very, very challenging to get people to go out east.
Tremendously. The easiest one is to have a 24/7 care, and they fluctuate. However, with a lot of being a squeaky wheel, shall I say, when they change off from 3 days off and then back on, to have the same person come in over and over versus different people all the time. So I have this woman and this gentleman that relieves her every 2 weeks. He relieves her for like 5 days and then she's back on again. She used to be able to stay there all the time, but now I have like 5 people in this complex here who have AIDS, and it's very hard to find a good aide too, where there's not abuse.
Well,
Or,
Michelle, the reason that the 4-3 split is done is because the cost of care is expensive enough, and we don't
Correct.
want clients to have to incur overtime charges.
correct.
After an
Yeah.
aide works for 40 hours, a live-in is considered to be working 13 hours a day. So by the time they're finished their 3rd day, there's an overtime charge that we're looking at. And the state reg is, of course, a time and a half for overtime. So we
Right.
don't want people to incur that. So we do the 4-3 split. But if it's what we call live-in services, we usually don't have a big turnover in that. You know, the one aide does 4 days and then she goes home, the other aide does 3 days, and then the other one comes back. So it's more it's not a problem with turnover with live-in, it's a problem with the proximity, you know, where they're going.
One other question about the aides, like these particular people come from the Bronx. So it costs them, they'll take the train, it's a $75 round trip. And the agency doesn't pick that up.
Right. And I think all agencies are a little bit different, but Maureen, I think you talked a little bit about that as far as mass transit and how your aides often drive, but it is a difficulty. It is a difficulty because, again, when you're thinking about, it's just geographically, it is harder in Suffolk. There's no question, and Montauk in particular.
East End.
Especially in the East End. And now that New York City people have seemed to kind of do this influx of population out here, it's even more difficult. We have more cars than ever. And it's not even spring.
I know. Well, they came as soon as the pandemic hit, those that had homes
That's
over
right.
there.
Yes.
So it is a challenge, but things change day by day. And again, there's a lot of great agencies that may be able to help you. But as far as certainly for advocacy, we serve all the way out to Montauk. So
okay, great.
Thanks for being here.
Thank you.
All right. Take care.
Thank you, ladies. Wonderful.
Thank you. Thank you. All right.
Thank you very
Take
much.
care, everybody.
Thanks.
Take care.
Thanks, Nicole. You take care.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.